Appreciate it.
My name is Drew Poret. I'm one of the cardiac surgeons for those of y'all I haven't met. First, I'd like to just kind of start off on a bigger overview. As many of you guys know, I'm old. There's no one way to do this. From how I did it when I started, we used to give people 4 Versed and morphine as soon as they hit the ICU. And now, imagine what that would do to me now. We used to keep them intubated for 2 or 3 days. You know, the length of stay went anywhere from 10 days to 3 weeks. I mean, we would just keep them. We didn't, we used to have people have heart attacks. We didn't have the thrombolytics and the stents like we do now, and so we'd see perforated ventricles, inferior, anteriors, and 7-10 days out where the heart muscle just fell apart and did it. So what we do now is completely different than what we used to do. And we've gone from a death rate of about 20% with heart surgery down to we all run about 0.1%. We used to get once a week, we're going from the cath lab with the nurse riding, pumping the chest to the operating room, doing emergency surgeries. And surgery is very, very poor treatments for STEMIs. Surgery is good for 5, 10, 15-year survival, but it's not good for acute. And it's not so much you do a different operation, it's just the heart has a certain amount of reserve it will tolerate. And when it's angry with a heart attack and then you do a pump run, you do the stress on top of it, that reserve is really tough. So you guys see these people that have sat home and come in with heart attacks 72 hours out, multi-vessel disease with impellas, and you can't see the heart kind of climb. That's what we're talking about, and that's what surgery adds on to whatever stress they came in with. So there's multiple ways we can do this, and what I'd like to do is we're just going to start off talking about some receptors, compressors, what we use, then we'll get into hemodynamics and how we monitor them and how we know, and then we'd like for you to bring up any kind of scenarios. We'll just pick some dynamics, some numbers, kind of let you think through what you think we're doing with it and go down those roads. And if anybody has any questions, feel free to ask and stop me. So what are the most common pressors that we use? Leave that. Okay, what else?
Dopamine.
Beza.
Beza.
Neo? What else?
Vasopressor.
Primacor? So these are probably the main ones. 15 years ago, almost everybody used epi. Nowadays, you don't find a lot of people going down to epi, and it's because of the side effects of epi. So when you look at epi, we talk about receptors. We have beta 1s. What else? Beta 2s. Alpha 1. Alpha 2. Those are the main ones we look at. So for epi, what are we hitting? Epi is kind of a unique drug because it hits beta 1, it hits alpha 1, it's less on beta 2. What about dobutamine? It's going to be big on beta 1, some beta 2, but it's small, and then it's going to be alpha 2, right? It has no noradrenergic effects, so it doesn't work through adrenaline or like epi does with the alpha 1. Dopamine, it's kind of really unique. So if you start out at low doses, you get the dopamine receptors. What do you get when you get to the middle doses, around 5? Beta. And then when you get up to 10 to 15, alpha. It's very unusual with the rest of the drugs and how it works. Now what do these guys do? Norepinephrine, Levophed. Alpha. Primacor. Phosphodiesterase inhibitor. Yeah. So it takes and stops you from breaking down ADP. Beta 1s all work through increasing production of AMP to give you more building blocks to get to ATP. This works so well because besides going all the way to the beginning, it stops the breakdown and then having to rebuild it all. I started practice before we had Primacord. And we used to have it commonly where we would operate on someone. All we had really was epi and levofed and wide open and balloon pump. And it wasn't uncommon at all to have people die in the operating room because you couldn't get them off bypass. Nowadays, luckily, we don't see a lot of that. But Primacord was the big changer in that. So Primacord balloon pump with epi kind of gives you where we were max for a while with heart transplants and those things. We use that. Now we have Impellas. We have, left ventricular VADs. So we have a lot more options now, and we're getting ready to have the 5.1 liter Impella we can put in the operating room. So those patients that are really sick will actually stick it right through the aorta in the operating room, not have to fight the vasoconstriction in the legs, losing the legs, doing that stuff, and use it as a bridge to try to let them get better, then take them back, take it out. So that's going to give us one more option to handle the really sick patients. So when we look at all of these, when the heart comes back from surgery, we have a choice of which one we want to use, right? And you'll see different surgeons may have different preferences, different anesthesia have different preferences and those things. When we say this has dopamine, beta, and alpha, what it means is how we expect dopamine to hit that patient, right? So if you have a patient on dopamine at 3-5 mics, do you expect to see any systemic effects? No. We thought that if you put people that have renal insufficiency problems on a couple of mics of dopamine that it's supposed to help because it hits these receptors. None of the data has really played that out, but we still do it. But the data, the studies haven't really shown that makes a difference. The biggest thing we found in people with bad creatinines post-op is we didn't give them enough time for the dye to clear beforehand, or they were unresuscitated and behind, and we got further behind with that. When you get up to 5 to 7, 8 mics, we'll see beta effects, which means we see the heart rate go up, the inotropic squeeze go well. And then when you get up in the 12, 15, 20 range, then you get your alpha effects. You don't get any of that at the low ones. The two that I use the most are dopamine and dobutamine. The advantage of dopamine is if you look at a curve, and if you look at heart rate, it's going to go like this as you go up in your dose of dobutamine, right? Now, blood pressure tends to go like this. Does anybody know why?
It's beating too fast.
Yeah.
Can't get
So
it
heart
in.
rate's up, you don't have stroke volume. What's the other effect? Hmm? Dobutamine vasodilates. So whenever you have somebody on dobutamine, you're going to get vasodilatation. And at the higher doses, you get higher heart rate, so your stroke volume's shorter. You get less volume, then you don't tighten up peripherally. Okay. So when we talk about, everybody kind of cool on those? We don't use this one a lot unless they're sick. So typically you'll find that when they're coming up on epi, we've had trouble, they didn't want to come off pump or whatever reason. I use a lot of these even when I'm not worried about their squeeze, just for heart rate. And my belief is we have so many people with sleep apnea now that when they get narcotics, anesthetics, and we get them off that night, you'll have a patient that's just doing fine, and all of a sudden you turn around and they braided and arrested. And what's happened is they built up CO2 because they're CO2 retainers with sleep apnea. Your SaO2 does not drop till right at the end. So there's no way to monitor those people. So if you don't have some reserve in your heart rate, they just arrest. Now they come back quick usually. You go and pump on them a little bit, you shake them, you get them on some oxygen, and they come back and usually do okay. But it's just kind of one of those ones that it took a little while to figure out because you just have somebody just all of a sudden Brady on you. We can pace them. I like to keep them in sinus rhythm, so that's why we do that thing between 70 and 90 on the heart rate with the dobutamine the first night, is to keep them from going into bradycardia and then arresting with the sleep apnea. It's unbelievable how much sleep apnea is out there now. We used to do mini stenoscopies and send them home the same day, and we won't do that anymore because they go home with pain pills. They'll actually arrest at home. They're seeing it a lot in the OBGYN world where they have bigger women that have sleep apnea, and they do little small outpatient procedures, and they send them out from a surgery center, and then they arrest that night at home, and then it's a lawsuit, and everybody's excited. But you got a woman that's 250 plus, and she has sleep apnea, and they're taking pain pills, and the family's usually encouraging them to take the pain pills, and then nobody's with them. So sleep apnea as an ICU nurse is one that you really have to kind of pay attention to. What are you going to see if somebody's sleep apnea? What are your warning signs? Say you're taking care of a post-op heart and it's 1 a.m. What would tell you that make you worried that you might have somebody with sleep apnea? So you got a bigger patient, you've got it in your mind, he may have sleep apnea. We've already said it, you can't watch your SaO2.
You're talking about like snoring, and you're talking about somebody that's snoring, or you visually?
Well, say they're awake,
breathing?
they're not, they're sleeping, but they've been alert, and so we'll give them, they snore.
Change in mentation, snore.
Yes. You only get 2 warnings. They get to where they're kind of confused, and we wonder, did the pain medicine kind of hit them, or they just, a little bit out of it, but they get confused. CO2 builds up, they get mental confusion. And then the second is they start bradying for no reason. And it happens quick, because they kind of just go along, and they'll actually get confused. But the SaO2, your blood pressure, everything else looks good. So you go in there and look at them and talk to them and don't see anything really bad. What can we do to figure it out if we're worried?
Check a gas.
Get a gas. You can shake them awake and make sure they're breathing and talk to them and get them doing it, so you kind of go down that road. If you're worried, then you can get a gas. If we want to treat sleep apnea, say you got a gas and the CO2 is 58, what are our options? Okay. Old days we had to intubate them, but now you can just put them on BiPAP, and I'll get a lot of them that come in that I know have sleep apnea that aren't using a BiPAP machine. I had one just recently that sold his machine on Craigslist. Now, who would buy a used BiPAP machine? But anyway, he had sold it on Craigslist. What I'll do is I'll actually have them see them and go ahead and set them up just to put them on BiPAP that night. If they're real big and they're having, especially if it's a man and they're real sensitive to pain. We know why you girls have the babies. But I'll put those guys on BiPAP just to keep them from doing that in the middle of the night. It's really weird if we can get beyond the first night to the second night. I don't see it up on the floor, and I just assume it's related to narcotics and anesthetics. We know the narcotics will inhibit the center in your brain that makes you wake up and start breathing. So it's really kind of changed in these last years with a large percentage there. All right, now let's talk about, everybody's seen it. You're in the operating room, the blood pressure's good. They transfer them up to the unit, and when they hit the unit, they're always saggy. Their pressure's low, they don't look good. What contributes to these people having low blood pressure? We're going to divide the hearts up into 2. One is kind of normal LV. So say the LV is 45 or greater. And then we'll have the LVs, less than 30. These you can pretty much do whatever you want to, you're not going to hurt them. These get to be more difficult to manage. So when we're looking at the things we watch, which will be, what are the parameters that we're going to use for hearts or sick people? Anybody? Blood pressure? Just yell them out. Heart rate?
PA pressure,
Index.
CVP,
Okay, so let's go with the SWAN. We get a cardiac output, we get a PA. What else?
CVP.
Somebody hadn't said my favorite yet.
Your output.
But yeah, that's true, but that's different. You're so right.
Yeah, that's good.
Yeah, I'm being sarcastic. What else can we get from the SWAN?
Temperature.
All right. I'm gonna add one down here. Anybody want to add anything else in? Out of all those, we're going to use a combination of those to kind of figure out what we think is going on with the patient, how we need to treat them, which medicine we need to go up or down on, whether we need to give them fluid and all that. When we talk about patients' blood pressures changing, what are the things that will be variables that we need to consider in our mind that affect blood pressure?
Volume. Volume.
Okay, good, volume. So we're just going to call it stroke volume, just to make it easy. What does cardiac output equal? Yes. Okay, good. Stroke volume. What affects this? This is kind of what I'm thinking, so if it may not come right to you. What's going to affect the stroke volume? Obviously, how much volume is there?
And your squeeze,
Yeah.
contractility.
Say again?
Contractility, squeeze.
That's going to give us this, yes. But when we look at how much volume is in a person, and say we have 2 people, 3 people, they all have the same amount of volume, but they all have different blood pressures. What are the variables that are going to affect what that volume is? In the old days, we just used to think that you have a certain amount of volume, you can't really adapt that. But I'd say it's different now. Vasoconstriction, right? So if they're getting a lot of narcotics, they're on Primacor, the alpha ones won't tighten up, so they vasodilate and they peripherally get volume and it's not there to be pumped. So you have to look at what I call tone. You could have bleeding, so they're bleeding a bunch out of the chest tubes. You can have temp. They're real cold, they tighten up, they warm up, which you will see in the process every time you get them. You're doing fine, they start warming up, then the blood pressure kind of drifts on you. Anything else? I'm gonna add one more to it. When you're hypovolemic, there's only 3 things that'll make you have high urine output when you're hypovolemic. The body's set that when your volume gets low, you contract down, you don't make urine. But there's 3 exceptions to that. Anybody know?
Sepsis.
Early stage.
Not usually.
Sepsis.
That's more complicated, but we'll kind of stay away from infection right now. Sepsis is going to vasodilate you so much that it's actually a pre-renal, so the answer is give volume, give volume, give volume. This is going to be a little bit different. We're going to exclude sepsis. Say the perfusionist gave Lasix and you didn't know it. So diuretics will make you pee when you're hypovolemic. So if you have somebody that's hypovolemic, you keep hitting them with them, you can actually make the creatinine climb and do that. Syndrome of inappropriate ADH, that's the one. But there's the one that you guys see every day you work. It's an osmotic diuresis.
Oh, it's glucose.
Glucose, because we have so many people that are diabetic. Now, the funny thing about the diabetics is the ones that are poorly controlled with their sugars in the 2 and 3 and 400s, they typically don't have a bad osmotic diuresis. It's the ones that are fresh diabetics or borderline diabetics or maintained well, and then the stress of the operation bumps them up, and you'll actually see them be dry and they're putting 300-400 cc's of urine out an hour. So that's one that you kind of have to watch for in the diabetics. Now, why do we worry about them losing volume, vasodilating, why do we worry about the volume? Because it's this. Why do we worry about the output? What difference does it make if the output's good or bad? Why do we care?
Perfusion. Perfusion.
Perfusion. So what does perfusion mean?
You're gonna be able to perfuse your organs.
Good. So I'm asking you now is how am I gonna know someone's perfusing besides that number?
You're not.
Pulses, urinary output.
Good. Okay, so we'll put a square around urine output. You're gonna have better pulses if you're perfusing well. And then what's the other one that you can look at? Blood pressure and heart rate, you know, they'll drop with it. But what's the other one that if you wanted to prove, say the typical scenario is you got a 5-foot lady that has a swan in, and her readings are 1.1 to 1.3 on her index, but she's got great blood pressure, she's got a great heart rate, she's got bounding pulses in her feet. Do you believe the swan? No. So there's these two with stable blood pressure and heart rate, and there's one other that if you're concerned that you can order that will let you know that you don't need to worry.
Venous
Huh?
gas.
Yeah, pH. So if you get this malperfusion, urine output's gonna shut down, you're gonna clamp down and get real cold in your periphery, and then you'll get acidotic. Now, why do we worry about them getting acidotic? Because acidosis inhibits the heart function more, so you kind of get into the cycle where you're gonna go downhill. So, you know, in the old days, we used to give a ton of bicarb. Now the studies show that if you're not 6'9" or lower, the bicarb really doesn't make a bit of difference, but we do it all the time to make ourselves feel better. If you have acidosis and you just treat with bicarb, it won't fix it. You have to give volume. So these three things, if we have a number we don't like here, before I would treat that number, this is what I would want to know. You think about swans, we use the same swan in a 5-foot woman that we do in a 6'5" man. Swans work by measuring temperature from one place to another, right? And how long it takes and how much change in temperature you have when you go from A to B. So if you have the thing and it's curled up here, or if it's curled up there, it can be a big difference. So they're notoriously wrong on women that are small. And you'll see that if you look back, that you gotta be careful with that. Because you end up giving a whole bunch more fluid than you need to. So now let's talk about these things. Why does that patient hit the unit and they start dipping and getting down and all that? It doesn't. What variables can we vary?
Because of their temp.
Yeah. So one is they're gonna be cold, they're clamped down, they're moving them on the bed, you're doing this or that, and so we'll see the changes. In the old days, you would have people pick a PAD number or a CVP number and say, keep giving them fluid till you hit that number. I don't know if anybody's done that. Yeah, they just say, keep giving them fluid till your PAD is 18. And they didn't care whether it was 500 cc's or it was 5 liters. Does that seem right? No. But that's kind of how we've changed from beginning to end. So now to take that one step further, that everybody kind of agrees we're just not going to give fluid to hit a number. What are the ways, is fluid good or bad for us post-op? Does it matter if you give a bunch of fluid?
Diuresis.
If their kidneys are functioning well.
Yeah. The more fluid you give, the more fluid you have to get off. If you don't get the fluid off, and how quick somebody can get it off depends on age, kidney function, how sick they are. You're going to get more AFib. You're going to get more coming out of your pleurovacs in the tube, so they have to stay in longer. You're going to get more swelling on the wounds. You're going to get more wound dehiscences. And then you just get people where they don't want to move. They're just edematous, they don't feel good, and it kind of just adds together. So if you can avoid doing those things, you're going to stay out of a lot of the complications that are the standards that we watch for and monitor after heart surgery. So if you have a patient come back and you're trying to give them what they need but not give them too much and do that, what are the ways that are the most important when they come back to deal with fluid, to deal with how much you have to give them? One is going to be, what narcotics are they on? Are they still out and down? Are we giving them morphine and Versed and as soon as they hit the room? Are we giving them Diprovan? All that stuff has the side effect it's going to vasodilate. So their pressure is going to need more. You get them in the room, you get them sitting down, respiratory comes behind you and puts the head of the bed up like that. Now you got gravity in a set situation pulling the volume down, so blood pressure's gonna dip, we're gonna give them more fluid. So the ways over the years that we've changed this is that we've gone to extubating them quicker. What that equates to is that we get them off of pain medicine, anesthetics, whatever, quicker, so they tighten up quicker, so the pressure becomes more stable. We're able to not have to keep them on the ventilator, and if you do this any length of time, you'll figure out that we get into these big ups and downs. The renal failure patients, the patients that have the heart hypertrophied and thickened, which is the vast majority now, because of obesity, which causes a right-sided heart failure, sleep apnea, right-sided heart failure. I'll get in there and the heart will be this thick. You can hardly lift it up because it's gotten so hypertrophied. So those people become almost fluid dependent, because if their fluid gets low, you can hit them with all the Levofed or Neo that you want, and they'll go along and then they just stop. And it's not because they're tightened up, they're already tightened up, it's just they have no volume. And so those patients, you have to give volume to get them back up. And if they're vasodilated, then you're gonna fight it more because the volume's down below and it's not in the chamber. And that gets into a lot of this. Those people, you put your Neo up a little bit to bring them up, and then they're out of the roof. You put on a little nitroglycerin, and then they're down here, and you get into that big one. The longer you're on sedation, the more that it didn't reverse them from the operating room, the more stuff that's floating around, the more you're gonna ride that stuff. Historically, they would give 5 or 6 of Versed when we rewarmed on pump. Now, Versed takes a long time to go away, especially in old people. They're not doing that here now. So you're not gonna get them where they're just be sleeping until the next day, hopefully anymore. By changing it and slowly getting those better, 6-hour extubation became a marker for the STS as a quality marker, probably 10 years now. In the past, everybody just slept them overnight. We'd wake them up in the morning, get them extubated, and that's kind of how we did it. And then those markers, because there's studies that show people do better. So if you can get them off the ventilator quicker, if they're stable, if they're not bleeding, not all patients can do it, but if you tune them up on the front end and get them in a good place, the quicker you can get off the ventilator safely, not rushing, the less side effects you're gonna have and the less you're gonna run into the big up and down. And it's just a matter of all of these effects and what they cause. So everyone is trended towards trying to come off the ventilator sooner. And I'll be honest with you, when I first started doing it, I thought it was just because we were meeting some government regulation. I remember when they told us we had to send patients home at 5 days. We thought it was heresy and couldn't believe they were trying to be doctors and all that stuff. And now I average 2.7 days. It really does make a difference, these little steps, in how they do post-op, how quick they get back to walking and moving and going. So you'll see us doing a lot of this stuff in the unit, and it's not just because, hey, I want to say I extubate more at this time than other. The patients actually do better. And if you kind of see the differences, you'll start seeing they get well quicker, they move quicker, they get out of the unit quicker, you get your tubes out quicker because you don't have all that fluid to fight and do those. So the tone is the one thing you guys will be fighting with on Fresh Hearts all the time. Now, you get patients that are sick and they can't get well, and we're keeping them on Diprovan, they're intubated, they're on fentanyl. This is what you're going to fight. So the only way really around it is you have to give them a fair amount of fluid and keep their tanks full. And then when they get better, they have to try to get that fluid back off. And so if you get stuck going down that road, you really don't have a lot of choices. And that goes back to the sepsis road. You're going to give those people 7, 8, 10 liters of saline, whatever you have to do, because they're leaking so much of it out. So let's talk about different scenarios on these. What I would love to share with you that I think is the most important thing in taking care of patients, and I can't tell you how many times I've had a phone call where somebody calls me about this, and I'll say, what's the blood pressure? And they say, hold on. And they gotta go look. They come back, I'll say, well, what's the heart rate? Hold on. What's the urine output? Hold on. We don't ever want to think about these patients at one point in time. what we want to think about is what have they done since you got there, what kind of pitcher they were before, and what are they trending, because there's not one single number in all of this that matters by itself. It's going to be that picture of what the patient's doing. One guy I'll operate on, he comes out of there with a PAD of 46, and that's him. They got pulmonary hypertension, so that number at 46 for that patient doesn't matter. But if it went from 46 to 70 post-op, I'm gonna get real worried that we got a tamponade, that we've blocked off our tubes. But if I get another patient that came back with a PAD of 6, and he goes to 47, then that number means a whole lot. So the big thing to see in all of this is that no one number makes a difference. It's more of trying to see the whole picture and which way is it trending. Now, obviously, the longer you do it, the more you get away from the little small points and you see the bigger picture. When you first start, we're so worried about missing something. I remember when I was in medical school, I had enough books in my pockets to come out to here because I was so afraid that something would come up that I didn't know the answer to. So when you're doing your stuff, if you start trying to see the picture and you do it for a little while, you expect what's going to happen. Then you can be comfortable, you're taking good care of your patient, and when it doesn't do what you expect it to do, that's when it raises a red flag and you start looking deeper and figuring out, is that number something that's real or is it something that is just a bad number? These right here will give you bad numbers very frequently with nothing going on. So that's why you have to be careful. It's a calculated number. I personally don't use them. I don't even look at them because they're not trustworthy. And there's a lot of ways to get around it and look at it. So now let's kind of talk about, we're going to stay in this group for a minute. You have an LV of 45 or greater, basically a normal LV, which is a large percentage of who we operate on. Doesn't really matter what the age is. The answer for them when they have a low blood pressure is almost 99% of the time volume. You give them some volume. I prefer to give something that's colloid, that's thick, versus something that's water, saline or LR. So I tend to use 5% albumin. Only to increase oncotic pressure so that you're not having that water, it dilutes down their hematocrit. If they've been bleeding and their hematocrit is 21 and their pressure's low and you need to give volume, obviously you would give blood. So those are the kind of the things. This subset you have to be real careful about because most of these people are on Primacor. Does anybody know what the danger of Primacor is?
Vasodilation?
Yes. You give a weak heart too much volume and it goes into failure. You give a normal heart too much volume, say you made the wrong decision and you give this guy volume, it ain't gonna hurt him. It may dilute his crit a little bit, it may make him, have a little more fluid in his pleurovac or whatever, but you're not gonna hurt him. You give this guy too much volume and he'll go into fluid pulmonary edema on you, he'll cross his Sterling curve and then the output will start going down. This guy, as you keep giving volume and extending the stroke volume, the output goes up. This guy can fall off Sterling curve. So what gets difficult is you tend to want to try to tighten them up more. But the downside of that is if you tighten them up too much and you don't have enough volume, then we get into your malperfusion. So these are the ones you have to be really careful about. These are the ones where you want to see where that PAD is trending. These are the ones as they start getting a fever, you got to worry about. These are the ones that if you have to give them a lot of morphine, you're going to change all those variables because you're going to affect what their volume is. These are doing well and you sit them up in the chair and you get gravity now affecting your return to the heart, it's going to have an effect. So you just have to be cognizant of these, what is your filling pressure? And you don't always know 100%, but what you want to watch for is if you make the decision that it's a volume thing, you want to watch what they do when you give the volume. If it's a volume problem, you expect the variables you were worried about, blood pressure index, to go up as you give the volume. If you give the volume and that's not happening, then you realize you're on the other side, and that may be diuresis. With hearts, the first day, it's almost 99% volume. After that, it's almost 99% diuretics. This subset, the 15s, the 20s, the really sick ones, long operations, prolonged pump times, dissections. That's the group that you have to really be careful about. This group, you have a lot more leeway in them getting hurt. Okay. Is there any scenarios anybody wants to pull up that you've run into that you have a question about that we talk about?
Come on, guys, now's your chance.
Okay, let's bring one up. Somebody give me a blood pressure.
83/42.
Heart rate.
95.
Good number. Sat.
93.
How much oxygen?
4
2
liters.
All right. Index.
1.8.
Good number. Pulmonary pressures.
25/10. 25/10.
Good. Healthy patient. CVP.
8.
Oh, wait, you got saline running. It's 104. SVR.
We don't
Does that
care.
one even matter?
We don't care
Oh,
about
yeah,
that.
let's give him 1800.
Does that one?
Good answer. Tim.
98.
All right. We always have a pH because they all get a gas when they first come back. That's the one thing that I would recommend. I've never been in a unit where the nurses didn't run the vents for the post-op parts and extubate them and do the protocols. Change the numbers, do the things. And what it does is it's such a big part of the post-op patient, especially initially, that I think it's not fair to you guys that you're not doing that, but that's a whole different ballgame. Pulmonary people, they are designed for chronically ill COPDers, long-term intubations. They are not really what post-op get off the vent quick do that. So their whole way they staff, the whole way they do their responsibilities is set up for the long kind of marathon thing. So you guys are going to be frustrated in trying to get them to do the gas when they need to do the gas. To get here, you call them, it takes them 15 minutes to come and do it. And all that stuff makes a difference. The longer you're on spontaneous breathing through a straw, in people that are anxious, people that are older, heart patients, they get to us because they have certain personalities. They're not going to do well doing that longer. So that affects us being able to get off and doing that. So I would strongly recommend that when you get that first gas back, you guys look at it and determine in your minds what it means. Okay? So as we go, let's leave this alone for a second and just talk about blood gases for a second. What are the components? So we know it's going to be a pH.
CO2. O2.
O2.
Bicarb. Excess.
Base excess.
Okay. So pH, below what number do we consider acidosis?
7.35.
Okay. What would be a normal for CO2? Around 40?
45.
45? Normal for O2? No such thing? So we'll just say greater than 80? Bicarb?
22 to 26.
Sat, you want to just say greater than 92? So if we have a pH that is 7.26, we have a CO2 that is 43, we have a PO2 that is 112, and we have a bicarb that's 16, and we have a SAT that's 95. What kind of acidosis is that?
Metabolic.
Okay. Would that stop you from extubating somebody? They have acidosis, the thing says, call the doctor. Does it worry anybody? What do we need to look at when we have this picture?
Fluid.
Perfusion. This is a perfusion problem. This is classic for a diabetic. Remember I talked earlier about a lot of people used to use epi? This is the one main reason why you don't want to use epi. It makes your sugars go up. It makes you acidotic, and especially in diabetics. It has to do with where it hits in those, but if you get people on epi, you can almost be guaranteed that you're going to have acidosis in diabetics. The only way to treat this is better is you want to, one, figure out what's making you not perfuse. 99% of the time, like we said, it's going to be volume. So this is somebody that you'd given, typically at this low, I'd give an amp-bicarb, give 500 albumazole or 250 albumazole, and then plus or minus a second amp once the fluid's in, then recheck them in 20 minutes or so to make sure that it's coming up. The reason we worry about it is purely because it'll be a negative effect on inotrope with acidosis on the heart. Otherwise, it's not really going to hurt anything, but you'll get into more acidosis, and it's just a sign telling you. But a lot of times they come up from the operating room this way because the CRNAs have been popping them with levo and not giving them volume, which is the right thing because we hold them to 600 cc's of saline the whole case, so that we don't dilute them down. We don't have to give them blood when we're on bypass, especially the small women that don't have a big circulatory bed. They do not tolerate the crits will drop. I did a whole bunch of Jehovah's Witnesses. So I had to come up with ways not to lose blood, not to have to transfuse, and got really good at doing that. And then it all of a sudden dawned on me one day, why aren't we doing this for everybody? We know that if you transfuse 1 unit of blood, you affect long-term survival. Now, I was shocked when I read that study, but you give 1 unit of blood, you have affected their long-term survival, which is kind of scary. The second scary thing is if you look at STS database, which we can all look at, the national average, the whole United States for giving blood with a pump run, does anybody have a guess of what percentage that is? 48. 1 out of 2. That's a lot of blood. Now that counts blood, fresh frozen, cryo, platelets, that stuff. There's a lot of things you can do in the operating room to lower fluid. There's a lot of things you can do when they get back up where we don't want to give them saline and do that stuff because it knocks it lower. You can get them extubated quicker. And all that stuff's designed so that you don't dilute them down and have to give them blood. There's a point where your crit gets to where people won't tolerate it. Too many things fail, and you see them kind of just fall apart. You've ever seen people really sick and their crits around 18 or 20, you're in a whole different ball game. And they get down that low, they can't make clot, so they bleed more. And you start chasing your tail, and then you're pumping 6, 8 units of blood or whatever. And then you got to give products because you've lost your whole blood volume and it had all the products in it, and red cells don't have any clotting factors. So it starts that whole ugly cascade, and much better to avoid it. So this is kind of the thing you're going to see a lot on patients coming back. This will be 18, it'll be 21. The diabetics almost all are like this. And that's what you kind of think about. Now say we do this and we do that. SAT's great, PO2's good. Does this worry us?
Mm-hmm.
Why?
Not breathing for CO2.
Yeah. We're not exchanging. That's going to be they're not awake enough. They're hypoventilating, either low volumes or low rate. So we definitely wouldn't want to extubate with this. If you kind of, everybody's heard my little spill, if you want to look at extubating a normal lung that's not got chronically intubated for 2 weeks, you can do it very easily. You want to make sure the reversal's gone. You know, they paralyze them when we operate. So if they can lift their head off the bed, the reversal agent's gone. They can move their hands, follow commands. They lift their head up, the reversal agent's there. You have them take a deep breath in and blow it out. If they can blow out over 600, 650, then your mechanics are good. And then this is what you use as your final, and this guy will be the one that goes apneic. So I'll take and put them on spontaneous for about 15 minutes, and all I'm looking for is do they go apneic. If they go apneic, then you still have narcotics on board. You give them some Narcan or let them rest, give them another 30 minutes and try again, then you can get them extubated. And those three things will tell you whether you can extubate somebody quickly or not. That's not how you would do somebody that's been on a ventilator for a week. Just post-op, quick hearts that are in good condition. So this will be something you see, we put them back on a rate for 30 minutes, try them again. This is what we're avoiding when they go apneic and why we put them back on a rate and don't let them just sit being apneic. Okay? Anybody have any question about that on gases or any questions about gases? PO2 you'll run across. It's real common in young guys that are big smokers. You'll get your stuff back and your PO2 will be 63. He's wide awake, he's about to jump off the bed, he's breathing, he pulls, 1,000 on the ventilator, but this will be 63. Is he safe to extubate? Blood pressure, bleeding, everything's perfect, but his PO2 is 63. Y'all seen that?
Mm-hmm.
Yeah. What's his problem?
Carbon monoxide?
From
From this
fusion.
one?
It's the oxygen crossing. So you can safely extubate these people, but they will be on high flow oxygen for a certain amount of time. It's the weirdest thing. They'll go 5, 6, 7 days having to be supported on pretty good oxygen, and then it just goes away. I can't tell you why it is, but I see it in, usually it's younger guys. I saw it at the VA all the time because they smoke 3, 4 packs a day, and they have some kind of reaction, and they just get to where they can't get their oxygen to cross. But they tend to do fine. You just have to use supplemental oxygen. Nowadays with BiPAP, we can get away with people that are on the edge, sleep apnea, morbidly obese, and get them off quicker and still support them without having to stay on the ventilator and fight all the volume and the fluid and the other stuff. That's been a real change. We just have to be really careful about aspiration. So on those people, you have to be careful the first night not to push them to drink too much or do that stuff, just because your risk of aspiration with BiPAP is higher. Okay? All right. Let's go back to our patient now. So we're a little bit hypotensive, we're a little bit fast, we're oxygenating okay, we got a borderline index, and we're showing a picture of volume overload, volume underload.
Underload.
Under. What if this was 200 and you had those numbers?
Wouldn't trust it.
What?
Wouldn't trust it, right?
Right. Typically, if this number is real low, it's supposed to be high when you're dry, right? When this number's low, it's usually almost narcotics. That's the vasodilatation thing that you can watch and see in your SVR sometimes. They either, they're sedated, they're whatever, they just got morphine. The guys that are on chronic narcotics goes nuts because they've affected their peripheral squeeze so long that they almost all become volume dependent, like a renal failure does. Their aortas are real thick and they can't dilate and go up and down like they're supposed to. So those people, I don't know if you've done a lot of renal failures, but they will really be up and down for you because their pipes, they're like lead pipes. You go exercise, your heart rate goes up, you pump more blood, but your blood pressure doesn't change. It's because your arteries dilate, your aorta will dilate, and it maintains it so you get a lot more delivery of oxygen and nutrients so you can do a marathon or whatever you're doing, but you don't see the big peak in blood pressure. Most of our patients, you give them increased volume, they get tachycardic, panicked, you see their blood pressure go straight up with it because they've lost all those effects due to the disease in the arteries. And that's, you'll hear me come back and say this one's going to do this because they're hypertrophied and their arteries are real thick. That's what I'm talking about. Instead of having the normal response where you do pump and then you get more output, their blood pressure just goes right with them. So if they get real agitated, the family's in there when they're waking up, whatever the situation is, they're a young man and they're just a wuss, they're going to have their pressures go up. The quicker I find that we get those off the ventilator and the quicker they kind of settle down, the tone settles down, I find you have less of this and you're not chasing them around as much. All right. Anybody have any questions about that scenario? What would we do? What would you want to do to fix this one?
Give them a little volume.
Give them a little volume. We would expect him to be, pulse is a little lower, feet cold maybe, urine output marginal or going down, just depends where you are in the thing. But that's probably the scenario you're gonna see no matter what these numbers are. They usually go down from what they were when they first got there. That's why if you kind of looked at the numbers and looked for the changes, if the PAD was 47 over 28 and then it goes down, then that makes you more comfortable that you have your diagnosis right. The reason that the PAD we worry about is it's your first kind of indicator of tamponade, right? So you have this picture and it was due to tamponade, you would have seen this number. Can't trust this one as much because where that's measured depends a lot on the length of the swan, right? So it can actually be up inside of the introducer in small people, instead of being where it's supposed to be is at the CVP. So that's why you know, and then if you're pumping anything through pumps, this is affected. So I don't get too excited about that number, but this number's a good number, but it's purely the change. If before surgery, it was 47 on your PAD versus 10 normal. It's not one's better than the other, it's just the change. So if this was gonna be tamponade, I would expect that this went up from when that patient came back. If it's gonna be, oh, that's just the boss. If it's gonna be volume, I would expect that this went down, right? So having an idea of what it was when you have the picture of when they came back, and I would even say not so much when they came back, because they never usually come back well. You have to kind of tune them. But once you got them to where you're happy and you think they're doing well, get a good picture of those numbers in your mind of where they are. Then when time, as they warm up, they change, they do that, I would think about how did these numbers change compared to where I thought we were in a good place, and look at that. And then as you go, you can just kind of watch those changes. We used to get real aggressive about this number. We used to chase it. You know, it was 1.9. Oh, we better get it back up over 2. I don't really worry about it too much if these things are good. You get a young person up there that's healthy, this number will be 6. They'll be putting out 300 cc's of urine an hour with a good blood pressure, and it's fine. So that's probably the most common scenario you're going to see. They're warming up, so they vasodilate. We've got them off the ventilator, or they're there and they're hurting. You know, they're starting to wake up, they're hurting, so we give them narcotics. Some of them get a little bit of a fever just from the dynamics of the operation, and you'll see them actually get a little high. That'll make them do more of this. They're bleeding and their crit's low, so they clamp down. It just depends on which scenario. All right, does anybody else have another question on a scenario? Okay, I'll make one up. Let me ask you guys a question. What do you think is the hardest patient to take care of? Which is the one that worries you the most when they come back? Is there any particular one? I know for me, I don't like the ones that are not responding appropriately and not acting right mentally. Because you know, you're always worried about, is it medicines, is it stroke, is it, you know, they already were confused on, is it sleep apnea? So for me, that's the ones that are the biggest. So you'll always see me, are they following commands, are they moving, are they doing what they're supposed to? So those are kind of the ones that I don't like. But I'm very comfortable with the hemodynamics, and we have the advantage of seeing the heart in person, seeing what the numbers are doing before I cut, watching what the heart looks like, and then seeing what they look like after I come off bypass. So you get a much better idea of what you actually see the heart's doing. When I bring mine back, I'll try to give you a good indication of what I think the ejection fraction of the heart is. Because to me, that's the key thing when you're going to treat them. If they got a normal EF, they got normal heart function, then the answer is almost always volume. If they're weak and they've had a massive heart attack or whatever, and you're on Primacor and Levophed and that stuff and Epi, then you're going to have to be a lot more attuned to what your volume status is and what's going on. And they're going to be a much harder patient to manage. Now, what you almost always have to do is kind of tank them up a little bit because you're going to keep them sedated and intubated. So you don't have the ability to get them off quicker and tighten them back up on their own. So those patients, you got to get your stroke volume where it's good, but we can't give them too much. And those are the ones you got to watch that you just keep creeping up on the levo without looking at what this is. And those are the ones I think from a managing standpoint are the most difficult because it's a changing thing the whole time. You're going to be kind of going up and down on the drips and that stuff. They're sick, they're warming up, they're going to have all the changes that we talked about. So technically I think that's the subset that's going to be the hardest. You get somebody that's been in the damn operating room for 6, 8, 10 hours, they've been on pump for a long pump run, you're going to see a lot of that. The heart's going to be angry, and you really have to baby those guys around on the first hours. I know you guys all seen those. And then once they start getting better, then you can tell. It's really amazed me. We used to do continuous SVO2s. We did continuous indexes or outputs. I've been kind of through the whole spectrum of that, and then you guys that know me know that I usually pull the swan 2 hours after I extubate now. This is what you were saying earlier. I know a heart's getting better the next morning when I give them 40 of Lasix and they pee. If they're sick, you can give them 100 of Lasix, they're not going to pee. So one of the best ways to tell that your heart's getting better, especially the first morning, is once if they're diuresing with the Lasix for you, then you can check a box in your head and say, oh, he's doing good, we're doing well. You give them that 40 of Lasix and they don't pee, then you got to kind of keep it in your mind, what's this guy's index, what's his heart AF? If he's on a border, then they're starting to reaccumulate their fluid in the morning. Don't want them to go over stalling curve, right? So if you get a heart that's weak and you give it too much volume, it shocks, that's what makes them go into pulmonary edema, right? A normal LV won't do it. But it's that 40 and below, depending if they're dilated or not. How much they're dilated really plays a huge role on it. How much they're dilated depends on whether we're going to help them with revascularization. Once the heart muscle dilates and gets thin, typically revascularizing them does not really step them up. Your main goal is to keep them from doing more damage that's not survivable. So those people are always really hard to take care of post-op because you're not going to see that normal being able to have a reserve and keep climbing. They're going to ride a fine line. So what we do is going to play a bigger role in those people. The madder the heart is, the quicker it was to the surgery, to the heart attack, the worse the LV. Did they come in pulmonary edema? That's a whole subset of patients that's going to be a pain to deal with. Luckily, it's just not the majority. If we can take those people and stabilize them pre-op and get several days to get them out of the heart attack and get them out of pulmonary edema, we can lower their risk dramatically. 72 hours from a STEMI or a non-STEMI, we can drop the risk from about 20 or 18% down to 1%. So nowadays, most people try to let a heart attack cool down and get over that. The operation's just the same, it's just they don't come off bypass. And if they do, they're just real finicky and sensitive post, and they're quick to go into failure if they get too much fluid. So is there any particular patient that somebody doesn't like or it scares them that we want to talk about? Everybody's quiet.
I don't like the renal failures.
Yeah, that's a good one. Renal failure we know will not make pee. I always dialyze mine the day before surgery. I think that sometimes they're Monday, Wednesday, Friday, and somebody wants to do them Wednesday and they had dialysis on Monday. I think you're asking for trouble. You're going to end up at 1 o'clock in the morning with a K of 6, and you're going to end up with a bunch of volume. So we're going to be calling a stat call to the dialysis unit to get somebody out there to dialyze them at 1 o'clock in the morning. So I like to dialyze mine the day before, that way I know what the volume is and I know what the K is. You'd like to have the K less than 4 before you do it because our pledge is K. So we know it's going to go up. The big problem with renal failure guys is you basically have to give them fluid, but they get real hypertrophy, so all their hearts are real thick because they all have high hypertension. The renal failure, 90% of them go down one of two roads: hypertension uncontrolled or diabetes uncontrolled, or the combination of both. It's rare that you have some of the congenital kidney diseases that you feel bad for them, but most of the renal failures have gone down a road that didn't just happen by accident, they just kept going down that road. So they all have real thick aortas, they have a lot of calcium in the aortas, so they have no ability to vasodilate and to vasodilate their arteries. So basically it's just up and down because they're totally volume dependent. Anything that makes their venous volume change is gonna make you go up and down. You give them a little medicine, it doesn't work, then the next thing you know, they're way up here than there. So the trick is to make sure that you keep their tank full and to try to make small changes on your drips. I wouldn't try to pick a perfect number and get to that. I would tolerate a bigger range on a renal failure. So if they were 90, to 130, if they would stay in that range, I would leave them there instead of trying to keep getting them right at 120. They just won't do it. You just end up kind of doing more of that. So as long as I felt I had good pulses and they're making, not making urine, good pulses, so they weren't acidotic on your gas when you came back, and your blood pressures are reasonable, I would look to try to get on a stable road. Each one of them will tell you what that stable road is. Some of them it's going to be at the upper end of the pressure, some of them it's going to be at the lower ends. But I wouldn't try to make them hit that number. For the longest time, we used to get really, really aggressive on bad hypertensive and make them their blood pressure 110 post-op. And then try to give them a bunch of medicine and keep them there. I learned a long time ago you don't want to do that because their bodies think they're pre-renal or dry, and so they start closing their kidneys down. So I'd rather see those guys up at 140, 130 and stay there, because you won't get the renal insufficiency, the renal failure, and the other things. And we control their blood pressure for 3 days in the hospital real tight, and they go home and go right back to what they were. So I don't try to treat those guys and get them down. I like to kind of let the patient tell me where they want to be, and then we try to keep them out of the danger zone, if you will, and don't try to pick one number that you think is perfect. And you'll know it. You'll see the patients, this one trends to want to stay here. And as long as it's not in a dangerous place, that's where I would tend to try to keep them. Somebody with a pressure of 95, 100, and they're making good urine and their perfusion, they're alert. Is that better than another one that's at 130? The other thing that's really kind of scary is the amount of antidepressant medicines that people are on now. So Prozac and some of these. Prozac's big cause of hypotension. I had one, I guess, 3 weeks ago that his pressures were staying around 80, 85, and we couldn't get off of a little bit of Neo, and he was on Neo for 3 days post-op. It was Prozac. We stopped the Prozac, and then he came up and we got off the Neo. I typically don't start the Prozacs and the other ones first post-op day. I usually wait till about day 3, but Prozac is the one that's more sensitive to being off of it and having a reaction. So I typically start on post-op day 2 or 3. If you get an order and you're starting that stuff back post-op day 1, just be aware that you can have hypotension in a subset of them. I think it's 15 to 20% of the patients. And it doesn't make sense because all your numbers look good, your index is good, you got a good pump, but they're just staying at a pressure of 80, and you just got them on like half a mic or a mic of Neo, and it won't come off. Does that answer the question about the renal failure one? I don't know who said it. Any other scenarios or questions? Throw them out there. Events you run into, something doesn't make sense, I can make up something.
So for somebody that has chronic COPD, what kind
Yes.
of things would you see post-operatively?
Good question. The COPDers typically have enough air at rest, unless they're on home oxygen. So say this patient has COPD, they're actively smoking, but they're not yet a home O2 person. Their biggest risk with the COPDs is they're so reactive. So they can go from being open airways to tightening down and wheezing and not going well. So the COPDers pre-op if you can get them where you can stop them from smoking for 3 or 4 days, it's worth it. So like if I see one that got an outpatient cath and they could have gone home and come back, but they're a big smoker, I will actually admit them, make them stay in the hospital where I can control them and I know they're not smoking. So one is I take away that. The second one is I usually use Mucomist to try to get them, not Mucomist, the expectorant, just to get them, yeah, Mucinex, thank you, to get them to cough, and then I like to use something to dilate them. So I use Opinex. I don't like to use albuterol because more of them go into AFib with albuterol, but the pharmacy will substitute everything to albuterol because it's cheaper. So on mine, you know, I just have to put an order in, do not substitute, but the Opinex kind of relaxes them. If you can get them 72 to 96 hours without tobacco, then typically you can operate on them and you don't have trouble. The STEMIs that come in and they were smoking on the car ride in, they, when I first got here, I did a lung for Dr. Pollard. He had it, but he had gotten in trouble with the heart or something and they were bleeding, so I offered to do that lung. Guy smoked 13 cigarettes on the drive in because he knew that we weren't going to let him smoke in the hospital. They put his ET tube in and smoke came out. Now I beat on all those people pre-op about getting off of cigarettes, at least for surgery, but typically if you have that time, then you can break that cycle. If you don't have that time and then you add the stress of an emergency on top of that, then you're going to go down the road of the vasodilator stuff. You're going to end up with steroids. We don't like to use the steroids because of what it does to the sugars and the acidosis, plus it affects wound healing. But that's kind of where you'll go with those people. Extubating those people, you got to get them from being tight. So the best way is they'll start moving more air, and then when you listen to them, you can actually hear the air go in and out. Wheezing's kind of the end, but then when you listen to them, even if they're not wheezing, they're just real tight. I saw a woman today that's got probably lung cancer that's going to do a bead on, and I listened and listened and listened. I could not hear any air go in and out of her lungs. And I know she has an FEV1 of like 0.7. It's horrendous. But so the real bad ones, it's just going to be a whole different thing. And typically I won't extubate those as quick until I'm happy that the lungs are stable. Because typically they also have bad hearts because they just don't take care of themselves.
Right.
The body will tolerate one thing angry at a time pretty well. You add heart, lungs, acidosis, alcohol withdrawal, whatever you add more in, the less like they're going to tolerate it. So when I take care of someone, I'm looking to what that whole thing is, and that drives me a lot of what I do or don't do, and I try to fix as many of those medical problems and other things on the front end. I believe it's much better with heart surgery to avoid a problem than to get out of it because our problems are so big. And people have lower and lower reserves now. They just won't tolerate a joke, and then we operate on a lot of older people. So if you get bleeding and you have to give a bunch of products to a 75-year-old, you've really affected their course and how they're going to do in the long run. So the more you can do to try to prevent that and maximize their lung function, that stuff. So when I come up there and say, yeah, he's ready to extubate, it's not just that moment or what I'm thinking about what happened in the operating room, did everything go smooth? What did I do the days before they got here? Am I worried about other things in them? And trying to just see the whole picture. But they're going to throw you into a different subset. Luckily, it's just not a huge number. But in the other part of your ICU, it's a huge number. I mean, your chronic pneumonias, your ones intubated, that's a whole different subset, luckily, than those. I kind of like doing what I do because I actually like seeing people get better. You may get those people through that episode, but they tend to come right back at it, like our endocarditis patients.
Okay, any other
Yes.
questions? You got it? Oh, go ahead.
The issue with the patients not being awake enough, if they've been reversed, and we've gotten them off their Diprovan, are you wanting us to go ahead and give them Narcan?
Yeah.
I know I didn't know if you wanted us to clear it with you.
If you're comfortable that you've
Okay.
worked with me and you know my routine, and let me just, for the ones that don't know, I'll tell you my routine. I bring them up on Diprovan because I want them to be kind of down to make sure they're not bleeding. You got time to get your lines transferred and hooked up, see what your pressure is. Once you do that and you're happy that we're in a good place, I like to turn the Diprovan off. I don't wait on the labs to come back. I don't wait on the x-ray people to finally get there. I turn it off. The beauty of Diprovan in my mind is you can turn it right back on and it works very quickly. So I don't see a bad thing. If we turn it off and their pressure's 190 and they're trying to jump out of the bed, I turn it back on, try to talk to them, then come off again. And there's some of the men especially that kind of the panic. You're waking them up and they just go wild. I just turn it back on a little bit, turn it back off, talk to them. And typically the second or third time they wake up, they do okay. So say a regular one that's not doing any of that, we turn the Diprovan off once we're stable. And my stable's probably a little quicker than y'all's sometimes. Because in the old days, we used to just wait. We'd get the x-ray done, we'd wait for the labs to come back. We just did it that way. And we used to leave them intubated 3 days. So it's all kind of just a spectrum. I won't do it on anybody I'm not comfortable with. I'm not happy that they've gone down the road I expect them to go down. So there'll be some of them that are older, whatnot, and I'll just say, we're not gonna extubate this one quick, we'll just give him time. But on the ones that we're talking about, which is the vast majority of them, once I turn the Diprovan off, they can lift their head up. I'm comfortable the reversal agent for paralysis is gone. I get them to take a deep breath in and blow it out as hard as they can. If they can blow out more than 650, then I'm comfortable that their mechanics are good. Then it just purely comes down to narcotics. So you put them on spontaneous, they breathe great, then they fall asleep, they go apneic, they have the monitor, then they don't. To me, that's just narcotics. They're not using Versed on my patients except for to induce them, and they're using low doses because they know I want to wake them up quick. They're not giving that 5 milligrams on the pump, which the old school way was that way. So you'll find they're going to wake up quicker, they're going to be ready to come off. If I put them on spontaneous and they have the apnea go off, typically I put them back on a rate, wait 10, 15, 20 minutes, let them, they look alert, and then I try them again. If they do it again, then I give them an amp of Narcan, because it's always narcotics. They'll wake up. If they will breathe there and it does fine, then I get them extubated. If they're still doing it, I give a second amp. If they don't do it after the second amp, that's a phone call. We're doing something different. I prefer to use one because if they go too far, then they're hurting bad once you get them off. Once they're extubated, I like to go to the pills instead of the morphine, just because I think it lasts longer. But you got to make sure you're happy they're chewing on ice, you're not worried about them swallowing and that kind of stuff. So obviously if they're hurting bad in that interval, you can give them some morphine. I tend to cheat the lower doses and try to titrate them versus just giving one set dose. And then once they're extubated, they're doing well, and they have a normal LV, then I pull the swan at 2 hours. Or if you call me too much and say the index is low. So if you call me and say the index is low, the first thing I'm going to say. And you've got the extubating gas. So if that gas comes back and they've got a metabolic acidosis, it's not that I won't extubate them, but I would want to know that, because then we give a little fluid and some bicarb. And the bicarb is really more just because we've done it forever. It doesn't really make a big difference, but it makes us feel better. Is that kind of what?
Yes.
And I don't mind y'all doing the Narcan at all, as long as you're comfortable. The ones that take care of mine, if you're comfortable with what you're doing, you have a good feeling of where we're going, I don't mind at all. I'll back you. If you're not comfortable, I don't mind you calling at all either. I do it a little bit different than what some are used to, and it's just a matter of where you do and how you train and that stuff. And I do it completely different now than I did 10, 15 years ago. It's an ongoing process. But I was shocked at how much better the patients do when you get them off the breathing machine quicker. But it's a whole process. It's the pre-op stuff. It's what we're doing in the operating room, trying not to give blood or fluid. And it just all adds together.
Okay. Thank you so much. We
Oh, you're
appreciate
welcome.
it.